Welcome to the second half of the course. Right now, we are entering into Module 7, and we're going to discuss behavior management, challenging behaviors associated with Alzheimer's, strategies and techniques for dealing with challenging behaviors, problem-solving approaches to challenging behaviors, and alternatives to restraints. UCLA developed a set of videos to address many of these behaviors, so we will be using these for a majority of this teaching. The first behavior that we are going to address is wandering. 6 in 10 people with dementia will wander. A person with Alzheimer's may not remember his or her name or address and become disoriented, even in familiar places. Wandering among people with dementia is dangerous, but there are strategies and services to help prevent it. And anyone who has memory problems and is able to walk is at risk for wandering. Even in the early stages of dementia, a person can become disoriented or confused for a period of time. So in the second part, I did put sleep disturbances and sundowning together because they often go along with each other. People with Alzheimer's and dementia may have problems sleeping or increases in behavioral problems that begin at dusk and last into the night, and this is known as sundowning. Scientists don't completely understand why sleep disturbances occur with Alzheimer's disease and dementia. As with changes in memory and behavior, sleep changes somehow result from the impact of Alzheimer's on the brain. Nighttime restlessness doesn't seem to last forever. It typically peaks in the middle stages of Alzheimer's and then diminishes as the disease progresses. The third behavior that we're going to discuss are hallucinations. When a person with Alzheimer's or dementia hallucinates, he or she may see, hear, smell, taste, or feel something that isn't there. Some hallucinations may be frightening, while others may involve ordinary visions of people, situations, or objects from the past. Hallucinations are false perceptions of objects or events involving the senses. These false perceptions are caused by changes within the brain that result from Alzheimer's, usually in the later stages of the disease. The person may see the face of a former friend in a curtain or may see insects crawling on his or her hand. In other cases, a person may hear someone talking and may even engage in conversation with the imagined person. So let's watch this video that explains how to handle hallucinations. Next, we're going to discuss agitation and anxiety. A person with Alzheimer's may feel anxious or agitated. He or she may become restless, causing a need to move around or become upset in certain places or when focused on specific details. Anxiety and agitation may be caused by a number of different medical conditions, medication interactions, or by any circumstances that worsen the person's ability to think. Ultimately, the person with dementia is biologically experiencing a profound loss of their ability to negotiate new information and stimuli, and it is a direct result of the disease. Aggressive language and behavior is especially difficult to navigate. People with Alzheimer's may become agitated or aggressive as the disease gets worse. Agitation means that a person is restless or worried. He or she doesn't seem to be able to settle down. Agitation may cause pacing, sleeplessness, or even aggression, which is when a person lashes out verbally or tries to hit or hurt someone. Now, there is something extra I do want to say about this. My grandma was a very sweet, funny Alzheimer's resident, but unfortunately, this is not the case for many nursing home residents. When I worked in long-term care, we had a very challenging patient at one point. I would walk into a room at night to check on her, and she would swear and literally growl and try to come at me. Now, I'm not going to tell you the year, but this is when physical restraints were still used and we didn't know about the dangers of them. This just made it extra difficult for the family because it was not their mother at all, and they would apologize to us all the time. So in these situations, it really helps to step back and try to focus on the fact that this is a consequence of the disease. So let's discuss a little bit. Let's watch the video on how to handle aggressive language and behavior. Apathy and depression are also very common among people with Alzheimer's, especially during the early and middle stages. Now, in this case, treatment is available and can make a significant difference in the quality of life, and we'll talk about that later. Identifying depression in someone with Alzheimer's can be difficult since dementia can cause some of the same symptoms. Experts estimate that up to 40% of people with Alzheimer's disease suffer from significant depression. The next thing we're going to discuss are repetitive behaviors. A person with Alzheimer's may do or say something over and over, like repeating a word, a question, or an activity, or undo something that has just been finished. In most cases, he or she is probably looking for comfort, security, and familiarity. The main cause of behavioral symptoms in Alzheimer's and other progressive dementias is the deterioration of brain cells, which causes a decline in the individual's ability to make sense of the world. In the case of repetition, the person may not remember that she or he has just asked a question or completed a task. The last issue I want to discuss are sexually inappropriate behaviors. And it is important to talk about this because it is very common. And I actually have a personal story about this with my husband. We were visiting my other grandmother in her long-term care facility during dinner time, and we sat down next to her. But as I was talking to my grandmother, her dinner companion took my husband's hand, began licking it, and asked if he wanted to go back to her room with her. Now, he didn't know exactly what to do, and I don't remember exactly what he did. I think he just politely declined her invitation and removed his hand from her grasp. But it's still a story that we talk about today. So this really is a real issue. Dementia can reduce a person's inhibitions, which may expose their private thoughts, feelings, and behaviors of a personal nature, and this includes sex. These actions are symptoms of the disease, and sometimes the person is just looking for a human connection. An Alzheimer's resident may use language that people have never heard them use before, and which seems very out of character. Or they may have impaired impulse control. For example, a family member who may have always been reserved could begin to remove their clothes in public. Such behaviors are not only embarrassing to watch, they could jeopardize the person's dignity and safety. Understanding that this is the disease talking and not the person will help caregivers cope. The last part to this module is to discuss alternatives to physical restraints. So let's define it. Physical restraints include any method or device which restricts a resident's freedom of movement or access to his or her body, and in which the individual cannot remove easily. In many cases, restraints are used because of the mistaken belief that they are necessary to ensure resident safety, prevent agitation, or physically support residents or prevent falls. Physical restraints are generally harmful to residents because of the negative effects on multiple body systems and interference with normal functioning, including a resident's capacity to walk, get food, get fluids, change position, toilet, and socialize. The physical consequences of using restraints may include death, injuries, falls, physical deconditioning, incontinence, malnutrition, dehydration, bone weakening, muscle atrophy, skin tears and pressure ulcers, contractures, cardiac rhythm disturbances, and infection. Emotional consequences of restraints include distress and worsening agitation. As always, there are some exceptions to this rule. If the patient is at risk for interruption of the medical treatment plan, such as pulling out tubes or IVs and being agitated, he or she meets the criteria for a medical surgical restraint. A patient who is at risk for imminent harm to either himself or someone else due to violent behavior meets the criteria for a behavioral health restraint. Now, some examples or devices considered to be physical restraints include any device that a person cannot remove at will. This includes limb and waist restraints, certain types of hand mitts, jerry chairs, over-the-bed tables and trays that cannot be removed without assistance, chairs or recliner from which a resident is unable to get up on his or her own, and involuntary confinement to a room except when isolation is medically necessary to protect residents from a contagious disease. Now, the care goals of any long-term care facility would be to foster a restraint-free community. This is why the assessment is so important. Using the assessment can help you find out about the resident's life history, habits, and preferences. Ongoing assessment is an essential strategy for identifying the use of restraints and alternatives to their use, as well as to support restraint-free care. Residents need regular, comprehensive assessment so that their individual care plans address needs and prevent the use of restraints for conditions. For example, some medications can cause dizziness, loss of balance, or delirium. Others can produce psychotic symptoms and the perceived need for physical restraints. And this is important to address. Now, staff approaches to eliminating the use of restraints is individualized care, which depends on staff knowing the resident as a person. So consistent assignment of staff to residents promotes this individualized care. Effective care planning involves knowing a resident's remaining abilities and understanding how to make use of them to avoid conditions such as wandering and falls that can lead to inappropriate use of restraints. Care planning staff are responsible for trying and documenting various options to avoid the use of restraints. Staff at all levels need to understand the hazards of using restraints and the process of individualized assessment and care planning to meet each resident's unique needs. Some examples of this are to respond promptly to resident calls and minimize their waiting times. When residents repeatedly slide out of their wheelchairs in an attempt to self-propel, place them in a lower height wheelchairs without footrests or with footrests in a closed position that allow their feet to touch the floor. Assign staff to identify and help fatigued residents go to bed when they need rest so they won't attempt to get into bed unassisted. Used individualized day and nighttime activities to increase resident contentment and decrease behavioral symptoms. Seek assistance from a professional to help reduce use of restraints through evaluation of and treatment of physical, cognitive, or sensory impairments. Camouflage and protect areas of active wound care so the resident will not disturb dressings during the healing process. Encourage family members and friends to sit with the resident and provide support or reassurance. Also, use pads and pillows to support comfortable and safe body positions. Adapt and tailor chairs to ensure comfort and safety. For wheelchair use, ensure that it is the correct size, comfortable, and in good condition. Respond quickly to physical needs such as hunger, thirst, sleeping, toileting, and exercise. Tailor care and caregiver assignments to residents' preferences. Provide therapy and restorative care to improve residents' abilities to stand, transfer, and walk safely. Help residents get in and out of bed as often as needed and desired. Now, in general, there are also methods to improve safety of all residents. Increase staffing levels to improve supervision. Adapt the environment through good lighting, safe beds, alarms, and other features. Remove accident hazards such as overbed tables with wheels and cluttered dining rooms. Provide safe areas for residents to walk. Train staff on methods to calm residents who are anxious or agitated and to identify and address unmet needs. And arrange mental health treatment for residents that need it. Now, long-term care facilities will have basic things like bed alarms or other alarm systems, and those in themselves are a little bit controversial. There are many products available as alternatives to physical restraints, and I invite you, or maybe you can invite the families, to do a Google search. I'm just going to mention a few of the more common ones here. The first one is a disposable freedom splint. This restricts arm movement without rigid arm splints and is not considered a restraint. Another one would be a self-releasing lap hugger. This is a soft lap cushion that fits snugly between the resident and the wheelchair frame to facilitate upper body positioning and helps prevent forward leaning. The next one would be a chair wedge. This can be used as a non-restraint product to help prevent people from sliding off their wheelchairs. The next one is a bedfellow positioning roll. This can be used to improve hospital bed safety, or it can also be used in a chair. And what it provides is full body support in the lateral or dorsal positioning, placing it around the patient in a chair to correct side leaning. Another alternative to restraints would be peekaboo mitts, and these are mainly used to prevent patients from removing medical equipment like IVs or devices to read vitals. Now, sometimes alternatives consist of simple material goods that you can buy anywhere. Sometimes they are more a matter of dealing with a person and meeting their preferences. Sometimes something very simple just has to occur to you, and sometimes different products need to be combined in order to form a good alternative.